We have Dr. Fiona Bishop. Fiona graduated from the University of Queensland in 1995 and is a Fellow of the Royal Australian College of General Practitioners, has a Diploma of Obstetrics and Gynecology. Fiona is also a HIV prescriber and is experienced in the management of HIV in the community, and is a recent member of the ASHM, which is the Australian Society of HIV Medicine, Treatment Guidelines Subcommittee. So Fiona's your person to talk to, what you really think about treatments. Before studying medicine, Fiona gained a science degree with honours in microbiology, worked in a HIV research lab. Her special interests are HIV medicine, of course, gay and lesbian healthcare, transgender issues and sexual health, as well as aspects of GP practice. Fiona also, many of you may know, reading the local gay mags, is Doc Q in Q News magazine, answering all of your tricky questions, and again, hopefully tonight as well. Thank you, Fiona.
I'm going to talk about the current treatment guidelines for treating HIV. I think we'll start off by talking about something that's very important in the guidelines, which is when to start treatment. So I realise we have a mixed audience tonight, and there are people here who've been on treatment a long time, and there are perhaps some people here who are not yet on treatment or have only recently started treatment or are contemplating going on to treatment. There's a number of different guidelines out there. The International AIDS Society now recommends that we consider offering treatment to all patients regardless of their CD4 count. The World Health Organization has recently suggested that we offer treatment to people if their CD4 count falls below 500. It was 350 and they've increased that to 500. Europeans are always a little bit more conservative and they're still saying 350, but they're saying consider at 500 as well. There's a little bit of variation there. The Americans, so that's the DHHS guidelines, are suggesting that we recommend treatment for all people with HIV and that we should be offering it to those with early infection regardless of their CD4 count. And of course that all pregnant women with HIV should start as soon as possible. Australia doesn't actually have any guidelines of our own, but we and the subcommittee that I'm a part of writes a commentary on the American guidelines, which is available online. We tend to follow the American guidelines to a fair degree most of the time. If we're going to talk about treatment, we need to talk about what the actual drugs are. And so there's 6 main classes of drugs that we use. The NRTIs, or more commonly known as the NUCs, and the ones that are commonly in use at the moment are tenofovir and abacavir, FTC and 3TC, much less commonly AZT, and in the distant past D4T and DDI. The second class I've got listed there are the non-NUCs, or NNRTIs, and the most commonly used one is efavirenz, and probably nevirapine after that, and rilpivirine, which is a newer non-NUC. We have protease inhibitors, and the commonly used ones are atazanavir, lopinavir and darunavir. Integrase inhibitors, at the moment we just have raltegravir, but we're about to get elvitegravir in the quad pill. We have an entry inhibitor, maraviroc, and down the bottom that actually says boosters. There's a booster called ritonavir that's commonly used, and there's a new booster called cabisostat that's going to be available in the quad pill. The guidelines have changed over the years, but essentially for quite some time it's been that we use a backbone of 2 NUCs and plus a third agent. The backbone that's most commonly used is tenofovir and FTC, which is also marketed as Truvada. Although some people will be on Kivexa, which is abacavir and 3TC. And the third agent, as I mentioned, those other classes, we have the non-NUCs, we have integrase inhibitors such as raltegravir, the PIs, and others. So what's available at the moment? On the left-hand side, we have the drugs that are currently available. So I mentioned Truvada, which is tenofovir and emtricitabine. Kyvexa, which is abacavir and 3TC. We have a tripler, which is a combination of Truvada plus efavirenz, and that was the first single tablet regimen to come along, and the only one for quite some time. And we now have Eviplera, which has been around for about 18 months or so, which is Truvada plus rilpivirine. And coming in early 2014 is the quad pill, which is called Stribild. And so that's going to be Truvada plus elvitegravir, the new integrase inhibitor, with a booster, cobicistat, so the 4 ingredients. There's a number of other fixed dose combinations coming our way, and probably we won't see these for a little while, but everyone's getting on the booster bandwagon, so we're getting a lot of drugs that are getting co-formulated with a booster. So we're going to see darunavir with a booster, we're going to see atazanavir with a booster added in, we're going to see a quad pill that's boosted darunavir plus basically a couple of other, a nuke backbone. We're going to see, hopefully perhaps towards the end of next year, I'm not sure if it's going to be that soon, we're going to see a co-formulation of a new integrase inhibitor with Kyvexa, and that's exciting because it's going to be the first single tablet regimen that isn't based on Truvada that we've ever had. So there's a lot coming. This is just to show you what the American guidelines are at the moment for preferred regimens. So on the left of the DHHS preferred regimens, and it's basically, depends on what your third agent is, but it's either going to be a tripler or Truvada plus a boosted atazanavir or darunavir, or the quad pill has been put in as a recommendation. They've got dolutegravir in the States, we don't have that here yet. Truvada and raltegravir. And the IAS recommended regimens are quite similar. They also have a list of alternative regimens, so if for some reason you don't want to use the preferred regimen, they have other suggestions, mostly involving substituting Kyvexa for Truvada, it would seem, and using some of the older PIs like Kaletra. Just so you can see from these slides, there are an enormous number of possible treatments that someone could be put on, all of which have a lot of evidence behind them, and so there's a number of possibilities of what you and your clinician can come up with as the best option for you. There are some issues with the current treatments that we have available. Tenofovir, which is in Truvada, which is in most of the treatments that are available, and all the fixed dose combinations, has issues for bone and kidneys. We know there's a slightly higher risk of osteoporosis in people who are on tenofovir long term. We also know there is a potential risk of kidney problems in people on tenofovir. Kyvexa, there's a presumed cardiovascular risk, although the evidence is not strong for that. Certain clinicians are quite wary about using Kyvexa because of that. Efavirenz, well, anyone who knows anyone who's been on efavirenz, which is in a tripler, will know that there's a potential for central nervous system side effects, which for some people can be quite significant. And the protease inhibitors have an effect on lipids, and amongst other undesirable side effects like diarrhea. So our treatments work, they work really well, they're not perfect. I wanted to talk about the new fixed dose combination that we've had for a while, which is Eviplera. Now, for ages, a tripler was the only single pill that was available, and a lot of people really couldn't take it or had terrible side effects with it. And they've been waiting and waiting for this pill to come along. Eviplera came along as a potential for people to use as an alternative single tablet regimen. It's basically a triplet with the efavirenz taken out and replaced by rilpivirine, which is in the same class as efavirenz, but anyway, so that's what's in it. It's not recommended if your viral load is above 100,000 because the studies showed there was a higher risk of developing virological failure if your viral load was quite high when you started treatment with Eviplera. And similarly, there was a high rate of failure if you started Eviplera with a very low CD4 count. And the other thing to mention about it is that it must be taken with food. So comparing rilpivirine with efavirenz, which is basically comparing Eviplera with Atripla, there is an improved side effect profile, which is what we all hoped for. There's less dizziness, there's less insomnia, less nightmares. There appears to be overall an improvement in psychiatric issues associated with the Atripla. There's less disturbance in your lipid profile. And there's a relatively small study which showed that if you switch people who are already fully suppressed on Atripla, so a patient who's been on Atripla and it's working and their virus is fully suppressed but they're having trouble with side effects, if you switch them to Eviplera, it does maintain their viral suppression at the 3-month mark. So it appears to be a safe thing to do. And I wanted to talk about the Stribild, the quad pill, because this is going to become available in Australia very soon, probably in the first quarter of next year. It's called the quad pill because it's got 4 ingredients, the 2 nukes in Truvada, plus elvitegravir, plus a booster. And there's some good data on it now. There's 96-week data. People doing studies always talk in weeks rather than years, so 96 weeks is basically 2 years worth of data saying that it's non-inferior to Atripla and also to Truvada plus boosted atazanavir. So we know it works, we know it works well. And the other thing is that it's consistent across a wide range of viral loads and T cell counts. So it doesn't matter if you've got a really high viral load or a really low CD4 count. You can go onto Stribild and be confident that it's going to lead to viral suppression. It appears to be very well tolerated. I'll go through a list of potential side effects in a minute, but it does seem to be quite well tolerated as a medication. There seem to be very low rates of resistance developing in people who take Stribild. So it's a robust treatment. We know that it does cause an increase in serum creatinine. Now, serum creatinine is one of the things we measure in people's blood when we are checking their kidney function. And so it is very important that we monitor serum creatinine. But we know that in the quad pill, serum creatinine rise is not actually related to a real effect on kidney function. So it's not something that we need to panic about, it's something we just need to monitor. It also needs to be taken with food. And as I mentioned, and this graph shows quite well, that there really was no difference in the ability to suppress the virus in people who were comparing Stribild with Atripla. So you can see the very similar rates of virologic success in the 2 arms of that. I mentioned side effects or adverse events with Stribild. I think the things I'd like to point out, and this is comparing it with Atripla, which is because there will be potentially people who are going to consider switching from Atripla to Stribild, or people who are thinking about going on to treatment and wondering which is going to suit them better. So I think the thing to point out is that there's far less of the abnormal dreams and insomnia and dizziness, which is a big problem for some people on Atripla. There was a slight incidence of nausea and diarrhoea, although in the studies I know that people were asked to report any episode of nausea and it was counted. So it didn't really measure how much nausea people were getting. So I know that people who've had experience with Stribild for a number of years in the States are saying it is really well tolerated and quite acceptable to patients to take. So that's current treatments. The next part of my talk is just about treatments that are coming our way in the sort of more medium term. On the whole, we know that the treatments we've got already work. So the new treatments, what are they for? It's basically about improving the tolerability of treatments. It's about reducing side effects. It's about reducing the risk of people developing resistance, improving the robustness of the treatment so that it will last the distance for people. So basically most of the new treatments are non-inferior to treatments you already have. Sometimes they may appear to be a little bit superior, but they work just about the same on the whole. It's about improving the way you take the pills or the way you take the treatment, improving the tolerability for the patient. This drug, tenofovir alafenamide, or TAF, is probably one of the more exciting things to come along for some time. It's a prodrug of tenofovir. Basically what it is it turns into tenofovir in your body, but you need a much lower dose in the plasma to get a much higher dose into the cells. So basically you're getting the drug where you want it, and you're not having high levels of it in the plasma causing your potential problems that tenofovir does. So TAF is currently in a phase 2 trial where it's being compared with, they've put it into a quad pill and compared it with the current quad pill. And so far it's only early days, but it looks like it's non-inferior, and it seems to have far less effects on creatinine and renal function, and less effect, or perhaps even a neutral effect, on bone density. So this is very exciting stuff, and I think that it's highly likely that in the future TAF is going to replace tenofovir in all tenofovir containing HIV medications. That's if they want to keep selling them anyway. Dolutegravir is a new integrase inhibitor, which I mentioned earlier. It's great because you only need to take it once a day, and it's going to be co-formulated with Kyvexa. It's non-inferior to raltegravir and superior to darunavir. It looks like it's a really good drug. The other thing that's very exciting is these new nano formulations. Nanoparticles are really, really tiny particles. They've currently got 2 drugs that they're doing trials on, dolutegravir and rilpivirine, which they've produced as these long-acting injections of nanoparticles. So the potential is there for a monthly, or perhaps more than a monthly or 2 monthly injection that people can have rather than taking pills. So it's a very exciting possibility, especially for people who have trouble taking pills or remembering to take pills. And there's a new entry inhibitor coming, which will rival Maraviroc because it's only once a day, and it's going to be co-formulated. So everyone's figured out that people want to take less pills, so they're all starting to co-formulate their medications, thank goodness. So the next part of my talk is about, so we've talked about the drugs and what's available and what's coming up. So there's new treatments around, and there are people who've been on treatment for a while who might be thinking about, do I need to switch my treatment? Do I need to go on to one of these newer, better drugs that have appeared? What are the problems associated with switching? So, to switch or not to switch? Well, I think that it's easy to get caught up in this idea that whatever's new and bigger and is going to be better and is going to work better and is going to impress people. And obviously, I had a conversation with my 17-year-old nephew who told me he was getting the new iPhone 5. And I said, well, what's wrong with your iPhone 4? Does it work? He said, yeah. Can you make calls with it? I don't make calls with it. Oh, well, can you text and tweet and whatever else it is you do? Yeah. Can you take photos? Yeah. Is the screen broken? No. So there's nothing wrong with it. So why do you need the iPhone 5? Because it's new. It's better. Okay. So I guess the point is that just because something's new doesn't mean you have to have it. It might not suit you. It might not be what you need. So why would you consider switching? Well, obviously, if your treatment isn't working, you need to switch. If you've got virological failure, it's a no-brainer. You've got to find an alternative. If you are experiencing intolerable side effects, obviously you need to talk to your doctor about switching. If there are safety issues associated with your treatment, if you've developed osteoporosis or renal disease, or your cholesterol's through the roof or whatever, if you have got too many pills and you're just having trouble taking them, remembering to take them, you've got too many, it's too costly, there are a number of good reasons for considering switching from the medication you're currently taking. Why wouldn't you switch? Well, I think that the old adage, if it ain't broke, don't fix it, is worth thinking about, because there are people who are on treatment that works, they're tolerating it, it might be an old treatment. I've got patients who've been on the same treatment for 10 years, 12 years, and they're happy with it. They're not getting any serious side effects. And every now and then we have a conversation about considering a newer alternative, but it's working, their virus is suppressed, their T cell count's great, they're comfortable. And for a lot of people there's a fear of what happens if I switch and my new treatment fails? What happens if I switch and I get a side effect and then I can't go back to the treatment I was on before? So there's a lot of fear around switching. I think that the answer is always to just talk to your doctor about it, discuss what are the particular issues for you, and if you're thinking about switching, to actually have a discussion about it and make sure that you are fully informed of what's available to you. And this is my last slide, which is a little bit controversial, but I thought I'd add it in. So we've got all these patients who are really well controlled on their treatment. They're virologically suppressed. They've got a normal CD4 count, and they have had for years. They've been suppressed for years. Do we need to keep measuring their CD4? There's been a bit of discussion about this. We know that viral load is a much more important indicator of the success of your regimen. In those people who have been successfully suppressed for a long period of time, do we really need to keep measuring their CD4? Do we need to keep measuring it as frequently as we do? Obviously, it's still very important in people who aren't on treatment, or in late presenters, or people who are failing or who aren't suppressed. But I just thought it was an interesting point that we might like to discuss at some point.